Welcome back to Easy Medicine. In today's high-yield cardiology review, we'll go through classic clinical cases covering mechanical complications of myocardial infarction, autonomic physiology, shock pharmacology, heart failure, and receptor adaptation. Case 1. A 64-year-old woman presents to the emergency department 4 days after being discharged from the hospital due to chest tightness and severe shortness of breath. During evaluation, she becomes unresponsive and develops cardiac arrest. Despite advanced life support, there is no return of spontaneous circulation and she is pronounced dead. Autopsy reveals a slit-like tear in the anterior wall of the left ventricle. This finding is consistent with left ventricular free wall rupture, an uncommon but catastrophic mechanical complication of transmural myocardial infarction that typically occurs within the first 2 weeks after the event, most often around day 5. The underlying predisposition is coronary atherosclerosis leading to a transmural ST segment elevation myocardial infarction. Following infarction, the affected myocardium becomes akinetic and no longer contracts synchronously with surrounding healthy tissue, creating increased shear stress across the ventricular wall. At the same time, coagulative necrosis and enzymatic degradation weaken connective tissue integrity. Eventually, the wall may no longer withstand high left ventricular pressure and rupture occurs. When rupture develops, blood rapidly fills the pericardial space, causing acute cardiac tamponade. Patients may initially experience chest pain and severe dyspnea followed by hypotension, shock, and rapid progression to cardiac arrest. Case 2. A 60-year-old man experiences recurrent witnessed episodes of loss of consciousness while shaving. Each episode begins with a sensation of faintness followed by brief syncope lasting less than 1 minute. Blood pressure is 130/80 and pulse is 80 beats per minute with no positional changes. Cardiac and pulmonary examinations are normal. This presentation is most consistent with carotid sinus hypersensitivity. The underlying mechanism is decreased systemic vascular resistance. Normally, carotid sinus baroreceptors respond to elevated blood pressure by increasing parasympathetic output and reducing sympathetic activity, resulting in lower heart rate and peripheral vasodilation. In some individuals, particularly older men, these receptors become excessively sensitive to mechanical stimulation. Activities such as shaving, turning the head, or pressure from a shirt collar can trigger an exaggerated vasovagal response. The resulting vasodilation causes transient cerebral hypoperfusion and symptoms such as presyncope, lightheadedness, and syncope. Because cerebral perfusion rapidly normalizes, symptoms usually resolve within 1 to 2 minutes. Case 3. A 78-year-old man with severe dementia is brought to the emergency department due to lethargy, fever, vomiting, and poor oral intake. His medical history includes emphysema, heart failure with reduced ejection fraction, hypertension, and type 2 diabetes mellitus. On examination, blood pressure is 60/30, pulse is 120, extremities are warm, and coarse rhonchi are heard over the right lower lung. After receiving intravenous fluids, the patient is started on a medication that increases peripheral vascular resistance, raises blood pressure, and lowers heart rate. The correct agent is phenylephrine. Phenylephrine is a selective alpha-1 adrenergic agonist with no direct alpha-2 or beta receptor activity. Its primary effect is peripheral vasoconstriction, which increases systemic vascular resistance and raises blood pressure. Because it has no direct cardiac stimulation, changes in heart rate occur through the baroreceptor reflex. Elevated blood pressure activates aortic and carotid baroreceptors, leading to increased parasympathetic output and reduced sympathetic stimulation. As a result, heart rate and myocardial contractility decrease reflexively. Pressor agents that increase blood pressure primarily through increased vascular resistance are particularly useful in distributive states such as septic shock. If this review helped simplify high-yield cardiology concepts, continue with the next Easy Medicine session. Consistent exposure to clinical cases is one of the fastest ways to build long-term retention for Step 1 in clinical practice.